Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester from the Overrun here. How we doing, Danny?
Doing pretty good today. How about you?
Can't complain, still coming down off the Eagles victory, but that's going to be happening for a long time for me.
This is true.
Today we found a paper actually from Austria. We're going all the way over to Europe, and we're going to talk about bolus versus continuous infusion of epinephrine. This is from Wagner et al. And what this paper looked at was they took porcine models, and this is an experimental paper, so this isn't something that's quite getting into practice just yet, but we thought it was interesting because the central theme of Magic Mondays is we have no idea what the hell we're doing for cardiac arrest. So just a quick note on this, and I'm going to go right to the conclusion. Continuous administration of adrenaline improved brain tissue oxygenation tension compared with bolus administration during prolonged CPR. Now, there's a lot of items to mention in this. Essentially, what they did was they took a bunch of pigs and they induced cardiac arrest, and they checked the cerebral perfusion of bolus epinephrine versus continuous infusion epinephrine. Dan, continuous infusion epinephrine has been talked about in cardiac arrest for a while. This seems to be one of the first, at least that we've seen, really, really good studies about what different epinephrine dosages do.
Yeah, there's a lot of people that have talked about this, and it's kind of a hot topic with FOAMed. I know Scott Weingart on MCRIT had it on a couple times, and he talks about some of his off-label use of epinephrine in cardiac arrest. The idea makes sense, though, if you think about it. When we're trying to give somebody a medication, we're trying to get a sustained effect. The best way to do that is through a continuous infusion as opposed to continuous pushes. We see this a lot with push dose pressors. Some people think that they're the cat's meow for everything. A lot of other people tend to think, hey, look, this will get it up for a little while, but if I need more than 2 or 3 pushes, I really should be putting this person on a pump. The idea of continuous infusion epinephrine is you get the alpha effects, you get the beta effects, you get it more consistently. It improves your preload and afterload, and maybe it improves perfusion without those up and down, shocks to the system like it does with push dose epinephrines.
Yeah, and it also takes into account the half-life of the drug, right? So, per the ACLS protocols, you have every 3 to 5 minutes for epinephrine administration, but epinephrine doesn't necessarily stay in the body that long. So it would stand to reason that, we're giving almost like these kind of like sine wave graph patterns as we're giving the drug. One of the things that I really enjoy on this paper is there is this graph that actually shows MAP, intracranial pressure, intercerebral pressure rather, and cerebral perfusion pressure. So if you're looking on this graph here, the blue line represents the bolus epinephrine and the red is the maintenance infusion epinephrine. What I really like about this graph is I feel it's an easy way to graphically show that if you're just infusing epinephrine, you don't have those peaks and valleys that you have with the actual push dose or the standard bolus dose. So what's exciting here is we think, right? Because again, we're not really sure in cardiac arrest, despite all the studies that we've done. We think that epinephrine might have some benefit. The data really hasn't borne that out. So there's a part of me that thinks that we're trying to find, a reason for epinephrine to kind of slide into the algorithm. Like, we're holding on to it for dear life. But in this paper, they analyzed 20 pigs, 16 were put into the final analysis. And this is what they found. When you give epinephrine in a continuous infusion, you're going to maintain the mean arterial pressure better than you would through a bolus dose. You're going to maintain intracranial pressure to cerebral pressure better than you would through a bolus dose. And the same thing with cerebral perfusion pressure. The porcine models, they used a Lucas 2 to actually continue compressions. And here we also see oxygen saturation through all of this. They go into lab values, which is much different than we've seen in most other studies. What's impressive is that the pH of the patient actually stayed above physiologic norms at 7.5 for both the bolus and continuous dose. So maybe that's something that needs to be looked at. But again, all the stuff that we look at in all these papers, right? This is experimental. They only use 20 pigs. Then they say, you know what? We have to look at different studies. We have to do more studies like this to actually figure out if this is effective and if it works. But really interesting, really promising stuff. And it's all the big stuff that we look for, right? We're increasing circulation, we're increasing oxygenation, we're getting all this blood to the brain because for 15 years now, we've been talking about doing, not so much CPR as, doing cerebral protective CPR. So I feel like this kind of adds to that where, all right, if we're going to insist upon using epinephrine, maybe we should be doing it more as a drip than actually an infusion over, bolus doses over time.
I think they're onto something here. And I know it's a small study, and I know it's pigs and not humans, and I know it's a proof of concept, which is great because this is the first step. I think that epi does have a benefit overall in the early stages of cardiac arrest. I think all the studies we've seen, all the papers we've read has reinforced the fact that there is a window for epi. We don't know how broad the window is, but we do know that it has a benefit. We also need to know what dose actually works. I mean, I'm old enough to remember the escalating dose epinephrine where we were giving, 1, 3, 5 milligrams, IV.
Just keep giving more.
Just keep giving more, like more gas, just more gas. On the other hand, there's a diminishing return at some point. So we've still got to find that sweet spot. But I think there's a spot here because you get a lot of good things with epi in a cardiac arrest. You get increased chronotropy, you get increased dromotropy, you get inotropy, you get systemic vascular resistance increases. There's some good things here. We just don't know how to use it optimally yet. And I think we're still trying to learn.
No, absolutely. And again, this is a pig model. So, there might be variables when you actually give it to human subjects, and there might be no benefit when you give it to human subjects. But when we're talking about the administration of epinephrine in cardiac arrest, we have to try and find what the most effective thing is going to be, right? And again, I think that there's valid arguments to be said, like maybe we shouldn't be, at least not doing it the way we always have been, right? Where, because, escalating dosages were a little bit before my time, but I came on right at the tail end of it. And, you hear that, and like, I remember I came on when Bertilium was still being used in arrests.
Yeah.
And, a couple of weeks ago, we talked about a paper where, all right, if we give intramuscular epinephrine at the beginning of the arrest, and then we move on to bolus doses, maybe that has an effect. So it might be that, the actual way that we work cardiac arrests changes. You walk in and you're going to give, you start your IO up in the humeral head, you give 5-10 milligrams of IM epinephrine, I forget what the actual paper suggested, into the shoulder while you're already up there, right into the deltoid. And now you have an infusion, you have an airway, you have your prime, your bolus dose, essentially that's intramuscular. And maybe that's the new route, right? So, it's difficult to know, but it looks like the data is sort of shifting more in that direction where, all right, maybe the way that we did things this whole time wasn't necessarily wrong, but we can update these kind of things. What I really am interested in seeing is now that we're starting to see these variable experimental epinephrine treatments, I'd like to see this evolve into looking at cardiac arrest holistically, right? Again, here we have a study where this was done in a lab. This is ideal settings, Lucas 2 devices on everybody. And I mean, like the way that this was done, and not at the risk of getting too graphic, they actually inserted probes directly into the cerebrum of the pigs. So this was done like very directional observation. Obviously, we can't do that to human subjects, so you want to try and get the best representation that you can get. It works very well with pigs. So it might be that now, all right, we have this fun little thing, we have this fun little thing. If we combine all these elements, this might actually improve outcomes. Now, what adds to the variability of this is we also have huge variables in cardiac arrest throughout the country, where we have, Dr. Antevi down in Florida has been reporting they have almost twice the amount of ROSC and survival of discharge than the national average. And all they're doing is training on CPR. So, this might not be that epinephrine is the key to it, but it may actually suggest, all right, if early defibrillation and early CPR are not available, right? And now we're already behind the 8 ball. We're trying to build up those catecholamines. We're trying to build up inotropy, chronotropy, trying to make that patient a little bit more sympathetic so that we can get that heartbeat. Maybe this is leaning into that direction.
I don't know. And what I think is,
I don't think any of us do. And that's where it gets fun,
Well, what we're learning is that cardiac arrest is an enormously broad range of conditions incorporating a lot of pathophysiology. And what works in one population isn't working in another population. It's very variable dependent. It depends on the right person at the right time, getting the right treatment for the right reasons, everything to work. We're still not at that perfect point yet. And I don't know that we'll ever get there, but this is a good start.
Yeah, and obviously, we're never going to get to perfection, right? We can't cross 10% cardiac arrest survivability in this country anyway. So the goal isn't perfection, but maybe we get this up to 12%, right? Where someone who's in cardiac arrest actually has like a real, viable shot at survival. But let us know what you all think. Have you read this study? This is coming out of Austria, so we don't know if data like this is going to be published in the United States anytime soon. But this is what's happening, right? Cardiac arrest research is still going on. It's a very robust data set. Check us out online. Look at everything we have on YouTube and on EMS1. Subscribe on Spotify and Apple Podcasts. For the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester, we will talk to you next week.
Take care.